Dear distinguished participants, welcome to the sixth of the medical webinar series conducted by the Global Healthcare Travel Council and presented to you in cooperation with the nearest university. All webinar series are broadcasted live on the official YouTube channel of the nearest university and the Global Healthcare Travel Council. Our guests in today's webinar are Associate Professor Dr. BILGEN KAYMAKAMZADE, Associate Professor Dr. Burcu Özbakır, and Dr. David AMILO. They will share with us their invaluable expertise on artificial neural network models for predicting in vitro fertilization outcome and the new horizons in IVF treatment. Today's session will be moderated by Professor Dr. EVREN HINÇAL and Professor Dr. MÜFİT YENEN from the nearest university. Professor HINÇAL.
Hello, thank you very much, Dr. Mustafa. How are you?
I'm fine, thank you, Professor. The
Thank
stage
you very
is yours.
much. Thank you very much. So, first of all, I would like to express my deepest thanks to the Global Healthcare Travel Council and the President Ahmet Savaşan to give us this opportunity to give this seminar with my colleagues. Our title, as you know, is an artificial neural networks model for predicting in vitro fertilization, and also some general idea about the modeling. So actually we are a bridge between the health and the mathematics. So actually it's a good opportunity for us to express our models, express our ideas to the doctors and to the guests who will attend this seminar. So let me introduce our speakers. So shall we start with Associate Dr. BILGEN KAYMAKAMZADE, which she will introduce the general idea about the modeling. So welcome, Hocam.
Hello, Hocam. Thank you for your announcement. Thank you for everything. So I should open, yes. So I want to talk about today some mathematical modeling for general mathematical modeling actually, but I will, if we summarize that, we will give an example, for example, predicting for YENEN fertilization outcomes. So first of all, as I told you, I want to give a brief information about what is mathematical epidemiology. And epidemiology is the subject that studies the patterns of health and illnesses and associated factors at the population level. And nowadays, most development countries are using this kind of mathematical modeling for fighting the disease and, of course, predict a good treatment. And mathematical epidemiology helps us to apply mathematics to the medical. And if you ask that why we might want a model, mathematical models allows us to formulate a hypothesis, simulate the scenarios, and explore the different parameters of the conditions. So if we have a complex structure, we can use the modeling and we can simplify it in a simple way. We can understand with using some mathematical methods of this, we can understand what is our problem, how we can solve it, and then we can turn the real life and we can use our results in the real life. So mathematical models plays an important role to understand the dynamics of the disease and provide a unique framework for studying biological process. And also it helps us to predict how we can find a good solution for our problems. So if we check the beginning of the mathematical epidemiology, First study of the mathematical model is given for smallpox, and it is given in 1760 by Bernoulli. After Bernoulli, some mathematicians increased their study extent, these kind of studies, and they studied about another type of illnesses, that's measles, like measles or something like that. And most useful one is given by 1927 by Kermick and McKendrick. And it is a compartmental model that it's most useful for us to understand our disease or treatment and find the solution. And it's a kind of input and output type modeling. And if we check how we can mathematical model use basic methods, basic steps, sorry. First of all, we define our problem, what we want to study, which area what we want to find a solution. And after we define problem, we should collect our data because we are studying the real data that our doctors collected from their patients. After collecting data, according to this data and what the problem, we define our variables that we want to use in our model. And after that, after collecting data, decided the variables and define the problems, we can create our model that we want to study on it. Of course, after creating the model, we should say that, okay, we have this model, but it is really work, and the results that we obtain can be used for the real life. That's why we should use some mathematical methods that we analyze our model with our data. And here, mostly we are using the sensitivity and stability analysis to analyze our modeling that we create. And after doing this kind of things and mathematical improvement, we can report our result with using some methods with numerical part in mathematics. And I want to summarize our studies that until now. We are studying this kind of studying, I think, in 2016 or something like that. So around 8 or 9 years we are studying about this kind of modeling. First of all, we start with modeling disease. So we are studying, for example, COVID-19 or something like that, that model this, understand the disease, and we try to apply some solution about this kind of illnesses. And we have some studies about the HIV, cancer type studying, bacteria, and nowadays the most popular one is IVF. We are studying about the IVF. And one of my PhD students wants to extend this kind of mathematical modeling with adding the neural network. And he extend our modeling for this kind of disease, and he study about this, and after me he will try to explain what he did until now. Now, if I want to talk about the modeling for IVF, we can improve the success rate of IVF procedures with using the modeling. And it is important to understand and model the complex dynamic involved in this process. And this approach offers a numerous advantages, including the ability to study scenarios that are difficult or non-practical to investigate experimentally, and the opportunity to optimize the treatment strategies based on quantitative predictions. And some powerful mathematical approach to that can be used in epidemiology, ordinary differential type of modeling, partial differential equation modeling, and we can use some stochastical type modeling. And here we prefer to use partial differential equations to modeling for IVF because it helps us to see the changes over space and time. And with using the modeling, we can the data from human embryos can be analyzed and identify the specific errors that lead to anomaly during the meiosis and the cell division process that creates eggs. And let us see the modeling, what kind of modeling we create for IVF. We created 9 parameters system for IVF. And according to our data, we have some, I think we have a missing part, sorry. All variables should be right in here, but I couldn't see. I hope you can see here. The first one, F, is represent as the number of follicles. R, number of retrieved eggs. G represent us for the number of mature eggs. And it continues like that. I don't want to explain all of them here because after me, as I told you, Dr. David explain most of things about these kind of things for you. So these parameters explain description of these variables are you can see here. And why we use this? Because according to our data, we have only this kind of knowledge for us. So with using this knowledge, we create this model. For example, if we check to the first one, it describes the change in the number of follicles over time and space. And here, if we can check the model, the first part, we can see it includes the diffusion effects and follicles, retrieval parts, maturation parts, and fertilization process for this. And if we check, for example, the second one, it represents the change in the number of retrieved eggs over time and space again. And here it accounts for diffusion of the retrieved eggs here and their productions from follicles and potential losses due to the fertilization here or other factors we can see from here. So as I talked before, this kind of mathematical modeling obtained by input and output types, compartmental method. So each one which includes inside of the first part, for example, and which one outside from this part. So with using this knowledge, we create this model that I just explained, just 2 of them here. With continuous this procedure, we can obtain all 9 conditions here. So if I summarize what I said, what we did here, the proposed model that we done include the various factors that affects outcome of IVF. For example, growth and mature of oocytes, the sperm-egg interactions, and development of embryos in the laboratory. And by formulating the system as a set of partial differential equations that I explained, we are able to capture behavior of the involved variables and investigate their impacts on the overall IVF process. So I want to stop here, and Dr. David AMILO will continue this kind of things, and he will give the results, what we've done with using this model, and he will extend this study on the neural network type of study. Thank you for your listen to me, and please, Professor HINÇAL, I'm stopping here. Thank you.
Okay, so thank you very much for Dr. Bilgen's valuable speaking. So now Dr. AMILO will continue her model, and he will explain us what he found actually as a result of this modeling. Dr. David, can you start your presentation? So we are waiting, Dr. David, because he will give the Bilgen Hoca gave the brief information. Now he will give us the details about the model and the results of his model.
Thank you so much, Professor. Can you hear me?
Yes, yes. Continue.
Thank you. Thank you so much. Good afternoon, distinguished audience, professors and doctors. My name is Dr. David AMILO, and I am highly honored to be the second speaker at this webinar. I am excited to share with you our ongoing research and development of the integrated mathematical models to neural networks in IVF. So far, so good. We have been in our quest to enhance the development and efficiency of the IVF procedure. Our team have put together this methodology, and we have been able to develop a predictive model. So stay with me as I take you through the intricacies and potential possible outcomes of our research and our findings. So this will be a quick summary. So without further ado, let's delve in. First of all, we would talk about neural networks, and in general, neural networks are subsidiaries of artificial intelligence. And for a quick definition, an artificial neural network are a type of machine learning models that take inspiration of the structure and behavior of the human brain. So they have the capacity to solve complex problems, recognize patterns, classify tasks, and make decisions in very remarkable capabilities. And as we can see in the description, what exactly we work with here is real data. And we take this data and we impute it into our neural network. We have a form of inner connection with the neural network and our mathematical model, somewhere within the hidden layers. And from this architecture, we are able to make predictions about what we are studying. And in this case, it is the IVF. And Professor Bilgen has already introduced the IVF model, which is a system of partial differential equations. And just to continue from where she had stopped, we can see clearly that we are dealing with real parameters. And in this case, the F of Tx represents the number of follicles, R the number of retrieved eggs, G the number of matured eggs, B the number of embryos with two pronuclei, S the number of sperm in the reproductive tract, M the percentage of motile sperm, E the percentage of sperm with normal morphology, P the number of successful implanted embryos, and U hormonal regulatory factors, and many more. So this partial differential equation is being integrated with our neural network, and in the subsequent slide we would see how. And as she has already introduced, that we are dealing with the IVF, which is classified as an advanced assisted reproductive technology, that has significantly impacted infertility treatment options until date. So we have several types of neural network, and as I said, that we would focus on the feed-forward neural network. The reason being that the feed-forward neural network is quite easier to integrate with our mathematical model. It has a structure of the input layer, the hidden layer, and the output layer. In the input layer, we usually put in our data. Within the hidden layer, we combine all our mathematical computations, as complex as they may be, and our output gives us a prediction from which we can relate to it. So when we look right here, what we see is a direct explanation of our neural network architecture for IVF prediction. And as I said earlier, we work with real data, so there's no guesswork. And following the feed-forward neural network, we combine these variables, the sperm motility, sperm morphology, sperm number, MI number, follicle numbers, all of which are being put in the input layer as a form of data. And then our hidden layer is where we combine our algorithm and our computations from our mathematical model, and then we make predictions. So, as I said, this would be more or less a summary. So here is a GUI of our IVF predictor user interface, from which a professional, a medical doctor, be it, that has this data can impute, perhaps they want to confirm if given this data from that they have collected, can they possibly have an IVF failure or a success? And what are the chances, what are the probabilities, even before trying it out? So we developed the GUI, and then this is just a screenshot. So they input this data. This is happening in the input layer. And then after imputing this data, they just hit the predict button, and our algorithm, which is combined as I have described, does the computations and then gives a judicious suggestion, okay, and prediction. So moving forward, we do not just use the model, we try to validate the performance of our model, and these are quite professional anyway. And then we also check for error analysis to see how far we are from our targets. And just to further delve into the prediction workflow that happens within the hidden layer, it does mix prediction and displays results, but however, it finds what they call best hyperparameters, okay? And such that it can further improve the predictions. So this is the workflow, the algorithm we are describing. And afterwards, there is a further prediction on the test sets. There are what they call some certain thresholds from which it makes its condition that helps it makes its final prediction, as we can see. So the mathematical model also gives us some outputs, and what we can see in some of these surface plots, in this case related to the hormonal regulations, is how sensitive they are and the roles they play in the IVF success. This is number of follicles, and it shows how important it is. In the subsequent slide, we'll summarize our findings, but let's still proceed with more of the algorithms and results. So back to our algorithm and our model, we further have what we call a confusion matrix, So because the data is actually being divided into training, tests, and validation. And what we honestly figured out is the more data we can gather, the more accurate our predictions from our model and algorithms could be. And in this case, we only used a moderate data. And as you can see, there is still room for improvement. So we have further more plots that tells us their relationship and their sensitivity between all of those variables that we had talked about, sperm motility, sperm morphology, and all of that. So we'll just quickly summarize our key findings because there are a lot more computations that are involved, but we'll summarize our key findings. The first key finding we found would be that monitoring ovarian response is crucial, with higher follicle density positively influencing IVF success by providing a larger number of eggs for retrieval. We found also that increased densities of retrieved and mature eggs enhance the chances of successful fertilization and subsequent embryo development. We also find that higher density of embryos with two pronuclei indicates successful fertilization, a high probability, and suggesting greater potential for implantation and successful pregnancy. We also found that higher sperm density is linked to increased chances of successful fertilization, emphasizing the importance of motile sperm and sperm with normal morphology. We also found that optimal hormonal balance is crucial for successful embryo implantation and pregnancy during IVF. Some of these findings are already known. However, the capacity of our algorithm gives us more chances that regardless of an unknown situation, given data, we can make prediction about the current situation. So we will just end here with a clean conclusion that the incorporation of mathematical models to machine learning and algorithms, as we have showcased, is a reliable tool in reproductive medicine. The model simplifies complex and high-dimensional data, enabling medical practitioners to make more accurate predictions and ultimately enhancing successful IVF treatment outcomes for individuals facing fertility challenges. So indeed, mathematical models and neural networks might be the future that we are looking for. Thank you so much for your attention.
So thank you very much, Dr. David. Thank you very much for your valuable talking. Thank you very much for your valuable presentation about health and mathematics. I think it's a innovative relations for us. So I don't know whether we have any questions or not, but we have already exceed our time. So I think what can I say as a last words? Our collaborative and efforts, I think, contribute to a healthier and more mathematically informed future for us. So thank you very much for listening us. So I should leave the microphone to Professor Yenen. Thank you very much for us. Thank you.
Thank you, Professor HINÇAL. Hello, everyone. In this part of our webinar, our third speaker is Professor Burcu Özbakır. She is a specialist on infertility and especially IVF treatment. And her topic today is New Horizons in IVF Treatment. Do you ready, Professor Özbakır? Do you hear me? can you share your presentation, please? We are waiting for Professor Özbakır. Yeah. She is.
Can you see the slide?
Yeah. Not yet, Burcu.
Okay.
You must
I
open
have
your
shared
camera.
actually, but
We can hear you, but we don't see your presentation, even you.
okay. Can you see it now?
Unfortunately, no. Yeah. Now we can see your presentation.
Yes. Unfortunately, I don't have the camera working. That's why I will just only be able to share my presentation today.
Okay, we are listening. Stage is you.
Okay. Thank you for listening to me today. We will talk about the new horizons in the IVF treatment and the Northern Cyprus a little bit today. Yes, this is me. That's why I couldn't share my video today. I put my picture so you can know who you are listening to. I'm Dr. Burcu Özbakır. I'm a specialized on the fertility treatments. Today we will talk about the new opportunities about the infertility. When we look at the big picture of infertility itself, we see that 90% of all couples that have the chance to achieve pregnancy can achieve the pregnancy spontaneously. But the 10% will not be able to achieve the pregnancy spontaneously. So we have a 10% of couples that will have the infertility. That was what we have known in the past 10 years' time. But in the recent years, we now know that the risk has increased to 14% for couples, which makes a huge bazaar actually for the patients and the health service carers in the field. When we started with the IVF, in 1978, we knew a little actually about the treatment procedures, and everything was new in the field, and we knew a little. In the meanwhile, we have learned a lot actually since Louis Brown. We will talk about a little bit about them today. One of them is ICSI. ICSI is pretty old actually. It's not a new technology anymore. In 1990s, we have evaluated that if we don't only leave the oocyte to fertilize by the sperm by themselves and choose the sperm and inject the sperm into the oocyte, then we would increase the chance of fertilization rate. It actually increases the fertilization rate for the specific cases, especially when the zona, the tissue around the oocyte is thick, or the sperm capacity is a little bit low, mild male fertility or severe male fertility issues, and some specific instances. But in the end, in general population, now it's very popular in the IVF units to use the ICSI, intracytoplasmic sperm injection, regularly, though it does not increase the chance of taking home baby percentages. But we are doing it to increase the chance of fertilization rate, of course. In the meanwhile, in the last 20 years, what happened in embryo growth, embryo culture medias, and incubators is actually 20 years ago, we were trying to grow the embryo from day 1 to day 3 stage, and we were doing the embryo transfer within that period of embryo growth. But now what we're doing is we are doing the embryo transfers. We're preferring to do the embryo transfers in day 5 or day 6 early in the morning. This is why is the reason that we are trying to postpone the embryo transfer to day 5 or to day 6 is the chance of the embryo to implant, to stick into the endometrial cavity in day 5 or day 6 embryos is much more higher than the day 3 or day 2 embryos. That's why we're increasing the chance of clinical pregnancy rates by that. But how do we do that? Actually, the embryo cultures have grown a lot in the meanwhile in the last 20 years, because when we take the oocyte outside and when we take the sperm and make the embryo is a very fragile tissue. It's very open to the light, the pollutants, the oxygen, and other conditions that may affect the embryo growth. Now we have new embryo culture medias which are letting us to grow the embryo until day 6 or sometimes to day 7 as well. And also we have new incubators. Incubators are the machines that we are growing the embryos in. They are mimicking the media, the around area, just like the intrauterine cavity or intratubal cavity. As the day of the embryo changes, the needs of the embryo changes as well. Because the embryo, if it was a spontaneous pregnancy, will not be only in the uterine cavity. It would start from the tubal cavity and then fall into the intrauterine cavity. That's why the incubator should mimic the surrounding area just as it has to be. That's why new incubator systems are increasing the chance for us to follow the embryos much more precisely than 20 years ago. We also have a new technology, embryoscope and time-lapse imaging. The embryoscope is the camera that is put into the incubator itself, which shows the embryo growth and also some specific timings that in the embryo growth happens. For example, when the embryo turns from 4-cell stage to 8-cell stage, or when the embryo does this or does that. We did not know that before the embryoscope, actually. We were just checking the embryos on the day 0 when the embryo was formed, and we were checking the embryo on day 1 to see how many of the embryos were formed, how many oocytes were fertilized, and sometimes in day 2 and sometimes we wouldn't check it as well, and then we would check the embryo growth, especially on day 3, to see how many embryos were grown, and then we were checking them on 5th day of the embryo growth in the blastocyst stage. But the embryoscope or the time-lapse imaging gives us the chance to evaluate the embryo or embryos at once and continuously. So we can know what's happening within the embryo within the time gap. So we can choose, actually, if we see the embryo 3 times throughout the embryo growth, maybe we will miss some information. But now with the embryoscope and time-lapse imaging, we are able to evaluate the changes in the embryo, and sometimes an embryo, 2 embryos may seem like each other, but when you follow the time-lapse imaging, you see that one embryo growth was actually later than the other one, and that one will lead less chance of embryo, less chance of pregnancy in the end. That's why time-lapse imaging gained a lot to the field, but nowadays the new researches are showing that Actually, even time-lapse imaging is not enough to evaluate the embryo itself to present the pregnancy. So we still do not know precisely which embryo will yield the pregnancy, even we know a lot about the embryo. We have the assisted hatching. Assisted hatching is not a new technology anymore, but it's still pretty new when we evaluate the time gap between the 1978 since the first IVF treatment. The assisted hatching is a hole making, simply a hole making in the zona of the embryo, the surrounding tissue of the embryo itself, which will make the embryo stick, implant to the endometrium a little bit better than a spontaneous growth of the embryo. It can be done mechanically, chemically, or laser-assisted methodology. In our laboratory, we're choosing the laser-assisted technology. We are doing an assisted hatching, as you can see in here. So it will increase the chance of the embryo to implant into the endometrial cavity, which will definitely increase the chance of pregnancy for some percentages. We also have the pre-implantation genetical diagnosis technology. In the last 20 years, it has grown a lot. First of all, what we were doing was the polar body biopsy. So when we were taking the oocyte, we were taking the polar body to evaluate the oocyte anomalies, but actually it was not showing the embryo anomalies itself. Then we started to take biopsies from the embryos, single cell biopsy in the 8-cell stage of the embryo, or trophectoderm biopsy in the blastocyst stage of the embryo will give us some tissues or some cells of the embryo to evaluate if the embryo has some genetical disease or not. These genetical diseases can be chromosome number abnormalities or single gene disorders, etc. So we can evaluate everything, almost everything genetically, if we know the situation beforehand. So if we know what we will evaluate beforehand, then we can design the probes and we can evaluate everything, almost everything in the genetical aspect in the embryo. So what we can do is we can say this embryo is ill, this embryo is ill, is not wanted, and these two embryos are healthy. So in the end, we are definitely increasing the chance of healthy pregnancy rates and also decreasing the genetically inherited diseases in the population. IVM is another technology that has gained popularity in the last 10 years. 5 years ago, it was much more popular than today, but IVM is in vitro maturation. The basic technology is we do the egg retrieval, egg collection, when the follicles, the little cysts that contain the eggs inside, before they are mature. We now do not use it regularly in the normal IVF, standard IVF patients, but mostly nowadays we're using it in the pediatric cases where the oncological treatment is needed, and before the treatment that will distort the gametes of the patient. The gametes, some oocytes of the patients are collected. They are getting more mature outside in the laboratory, and then we may end up with mature egg production. Then we can freeze those eggs for the patient when the patient heals up from the oncological disorder or some other disorders that might distort the oocyte quality. Then in the end, these people may have their own biological children in the future with IVF treatment. Then we have the sperm microchipping. The sperm microchipping has gained popularity in the last 10 to 15 years. It's like a labyrinth that the sperm is put into a chamber and waited for the sperm to pass the labyrinth to get out from the other end. Actually, the sperm, which has the normal morphology, the shape, and the normal motility, the movement, will end up with the end of the labyrinth, and that spermatozoa is shown to have less chance of genetical abnormalities than the regular sperm chosen in the IVF treatments. We are especially advising these kind of treatments to the people who have low sperm count, low morphology, or low motility disorders. We also have surgical sperm retrieval methodology for the patients, for the male patients who are not able to deposit sperm, or who are able to deposit sperm but has no spermatozoa, who are azoospermic in the sperm analysis. That's why we have the testicular sperm aspiration, that we aspirate the sperm from the seminiferous tubules with an injection, with a needle and aspiration. We have the testicular sperm extraction. We can take a biopsy from the testes. Percutaneous epididymal sperm aspiration, which is much more functional for the patients who have post-testicular problems of azoospermia. And we have the microsurgical epididymal aspiration is also working. And also recently we have the micro-TC, that we cut the surrounding area of the testes, and then we find the largest seminiferous tubules with the large caliber. Then we take the biopsy from there. So we increase the chance of the patient to have some spermatozoa found in the specimen. Then if we find the spermatozoa, then we use it in the IVF treatment as well, or we may freeze the sperm for future use. In these cases, if the patient is chosen correctly, the chance of achieving the spermatozoa is between 20 to 63%. So it's not low, so it's pretty high actually, it's not that low. The chance of patient from 0 to 60% is sometimes miraculous in this situation. We have also the stem cell treatment. The stem cell treatment is fairly new in the field. We can find the stem cells from various tissues or the blood. We are evaluating the stem cells to find out the concentrated form of them, and then we can use them in male or female fertility, infertility. What we can do is we can inject this stem cells, progenitor stem cells, to the testicular tissues to stimulate the spermatogenesis. And so we can use it for aberrant spermatogenesis, oligoastenospermia, which means that the low sperm count or the motility is low, or severe teratospermia, the sperm morphology is bad. In the female infertility, where we can use it is premature ovarian failure and polycystic ovarian syndrome, which increases the chance of the patient to end up with follicle formation with the stimulation, with the ovarian stimulation, to end up with egg production. The egg actually is not produced, but it's getting mature within the time, if possible. That's pretty new, fairly new, and the new researches are not proven to increase the chance of the egg production, the oocyte production yet, but still the researches are continuing. I hope in the future we will have better solutions for the patients who have ovarian failure. And also we can use the same material in the uterine adhesions and the thin endometrium as well. So we can inject the stem cells into the endometrial cavity, which increases the chance for the endometrial growth or the endometrial cavity to restore better than before. And for the patients who cannot have the oocyte production, we have the oocyte donation solution. As we all know, in the 20s, we have the optimal fertility for the female, and in the 30s, the fertility starts to decrease, and with the age 37, it starts to decrease much more faster. In the 40 to 45 years old age, the biological fertility for the female is practically ending, and afterwards, even if the patient has some oocytes, the oocytes, then the quality of the eggs is a little bit distorted within the time genetically. So we may not end up with healthy babies. We are not ending up with healthy embryos genetically. That's why many patients are going for oocyte donation who have low ovarian reserve. Failed recurrent IVF cycles may end up with oocyte donation. A genetical anomaly that we don't want the woman to inherit may go for oocyte donation, and advanced maternal age, as we have talked about, can go for oocyte donation. The oocyte donation is not something new. We get the egg from the donor, so the stimulation is done by the egg donor, and we fertilize the egg, the oocyte, with the partner's sperm and make the embryos, and we implant, we put the embryos back into the endometrial cavity of the mother. What else we can do for the patients who have low ovarian reserve is also cytoplasmic transfer. Why I have given this slide, why I have put this slide after the oocyte donation is it's actually a donation, but in the previous one, the regular egg donation, we are using the whole egg, the whole oocyte of the donor. But in here, we are using only the cytoplasm of the donor. So we can take the DNA, the genetical material of the donor outside, or we can take the cytoplasm of the donor's oocyte and inject it into the patient's oocyte. So the mitochondrial transfer is done. And in the end, the genetical material of the embryo is, of course, the biological mother's genetical material, but also will have some mitochondrial DNA of the embryo as well. What will this do is actually it is shown to increase the chance of fertilization rate, but not the clinical pregnancy rate so far. But as the fertilization rate is increasing, still there is a demand on cytoplasmic transfer. We also have tandem cycle option for the patients who cannot produce enough oocytes. So if the patient has poor ovarian reserve but wants to go on with the own egg and the donor cycle, so we can do them both. We collect the eggs from the mother and we collect the eggs from the donor. We make the embryos in different dishes and follow the embryo growth. And in the end, we transfer the embryo or embryos into the mother's endometrial cavity. In tandem cycle, of course, as we are using the donor eggs as well, the chance of the patient to achieve pregnancy is increasing a lot. Not only the egg donation, but we also have the sperm donation option for the patients who do not have a male partner or who has male partner but no chance of sperm production, azoospermia, who is not responding to the stem cell treatment, or who is not suitable for the stem cell treatment. In that issue, what we do is we use the donor sperm. The donor sperm is certified in the nearest university hospital, so we use only the qualified sperm as donor sperm. The patient chooses which type of information, which type of information about the donor, then we choose the sperm together and we use that sperm. The rest of the treatment is just like the regular IVF treatment. And embryo donation, of course. The embryo donation itself is for the patients who are single and advanced maternal age, or who have an azoospermic partner and cannot produce egg anymore, or a genetical disease is running in the family and they don't want to inherit the disease to the child. That's in that situation, both the egg and the sperm is donated. So we use two donors. We use the ovarian stimulation to the donor. We collect the eggs from the donor, and we use the sperm of the donor and make the embryos. What we do to the recipient in the meanwhile, the patient in the meanwhile, we prepare the endometrium for implantation. Then we do the embryo transfer to the patient. So this is a huge market. So I will talk a little bit about the Cyprus and start with the 5 W's and 1 H. Where is Northern Cyprus? It's at the connection of Europe, Asia, and Africa. It's a perfect, relaxing holiday option, and it is easy and convenient travel, containing easy and convenient travel options. So it's easy to reach. Who are the Northern Cyprus? It's a tasteful mixture of Oriental and modern culture. The people are hospitable and helpful. And very importantly, English is a well-known language. So the patients who come from abroad will not have problem with the language. What do we offer? As Cyprus, we have one university hospital IVF center and research institute, which I work at, the nearest university hospital. We have 4 hospital-based IVF centers and 10 boutique IVF centers. Every type of IVF programs, including the sperm and oocyte donation, the surrogacy, the conventional IVF, intracytoplasmic sperm injection, tandem cycle, sperm microchipping and sorting, and any type of genetical screening in IVF can be done within these centers. The patient can directly find the websites to contact, or direct contact options may be possible within the companies. We also offer the treatments to the patients. When should the patient come is another problematic issue sometimes, because the patient thinks that they will need to stay here for 3 to 4 weeks or maybe more to have the whole treatment. But what we do is we do pre-treatment consultations free of charge. So the patient is getting prepared in the own country with less stress, and starting the treatment there and staying here only 3 to 8 days up to the treatment modality that is chosen. And why Northern Cyprus is, we are in the first 5 throughout the world. The North Cyprus trend with the highest success rates is well known. We have the new technology and the innovation that is increasing the chance of pregnancy, and also the issue that the country is an island country and is a holiday country. The patient is less stressed, which is increasing the chance of pregnancy a lot, as the technology is very well known. And also, we have some low issues in other countries, in some other countries. There is sometimes age restrictions, and sometimes some treatment modalities may not be suitable in some countries, and it's not an issue in Northern Cyprus. There is no age limit. Basically, we are checking and evaluating the patients up to the need. We can do the donation, surrogacy, and many other types of IVF treatments legally in Northern Cyprus for suitable patients. There is no marriage obligation, so single patients can come, suitable for single women or lesbian couples as well. There is no waiting list for donation programs, is very important. And there are high standards for donor acceptance, which increases the chance of high quality oocyte egg production, high number of eggs, which is increasing the chance of embryo growth and the pregnancy rate, of course. In Northern Cyprus, we have the complete donor anonymity and 100% confidentiality rules. That's why the donor is completely anonymous and the child will never be able to reach the donor. That's very important for some patients as well. And we also have various pre-implantation genetical screening options. We can do the chromosome analysis screening, or we can do some specific genetical disorders in need if we know the disease beforehand, of course. When we offer this much, the costs are still lower than Europe or Asia, and the patient is having the holiday and treatment together, and we end up with high patient satisfaction, which is increasing the chance of pregnancy a lot. So, there is affordable and competitive price offer, liberal IVF regulations and wide choice of treatment options, easy and convenient travel options. The donations are completely legal and anonymous, and also the patient can do the holiday with the treatment itself. So why not Cyprus? Thank you for listening to me.
Thank you, Professor Özbakır, for this very nice presentation. And we are coming to the end of this webinar. I want to thank all of our speakers and, of course, all of you, and also to the Global Health Travel Council and its president, Ahmet Savaşan. And on behalf of nearest university, I wish all of you a very nice day. See you again in another webinar. Bye.